red dot on? I just wanted, yeah, perfect. Thanks, Steph. So welcome everyone to the first GP Forum for 2024. I hope you all managed to have a bit of a rest over the holiday period and ready to kind of gear up and for this new year. I'm chairing today because unfortunately I think Arpana is unable to chair. So I welcome you all to the webinar today. We've got once again a packed agenda. Just to remind everyone that the meeting is going to be recorded, and if you have any comments and questions, please use the chat bar and we'll be looking out for that as well. So let's just get going. We are hopefully joined by Dr. Chalabi's daughter today. And we all kind of share the very kind of sad news. I'm going to hand over to Dr. Sen, who's going to represent our Newham GP community to say a few words. So, right. Sabir, over to you.
Thank you, Rima. I think it's a very good thing to start with you. Because as we all know, that we had lost one of our very experienced, beloved GP. It's not nice. It's not nice to do these things. I don't want to do these things in the future. I hope everybody is healthy and wealthy. So, but then we need to do, because remember, they live with a lot of legacy. They live with a lot of experience, and there's a lot of pathway they create for us to learn. So Dr. Chalabi was a GP in Newham, and I know her about 20 years ago when I was to do a locum with her, and a very smile all the time, have been open-hearted, and she always used to embrace everybody with a big hand. I was doing a locum, and to be honest, the most important thing that I learned from Dr. Chalabi is the mutual respect. I'll just give one example. One day after the surgery, I was standing on the corridor. Dr. Chalabi and Helen Page, Helen Page used to work with me, and she was nurse there. So they brought an ECG meeting to ECG to show me. And I said, Dr. Chalabi, I will show you see the ECG machine. Before that, you have to tell me something. Can you don't just call me Dr. Sen? Can't you just say Subir? She paused. She said, no, Subir, Dr. Sen, I cannot do it, because I do respect the expertise and the skill and all the things that you bring to general practice. And I'm not respecting you, I'm respecting your positions. And don't stop me doing it, because this is the way I want to respect you, because you do drive a lot of changes in our life. So that really tells that being a very junior and local who doesn't have a long-standing relationship, the amount of respect she wanted to pay, I think that is outstanding. And for that reason, from that time, I can really trust those kind of words. That since then, Helen Page even started to speak to me, Dr. Sen, because doctor went in. So I just wanted whatever the mutual respect to us. With that note, I had a great pleasure to have two daughters of Dr. Chalabi. They wanted to talk something about their mom. They're very proud the way they raised two daughters. And I just wanted to invite Nadia and Mona to speak something about their mom that we don't know.
Thank you, Dr. Steph. There's an echo. Is it all right, the sound? Is that okay? Okay, great. My sister was wondering if she's allowed to share her screen. She put a slideshow together. Oh, great. And I'll just read a few words, if that's okay. So thank you for giving us a moment to talk to you today about our mum. We'd really like to honour both her personal and professional life. And we're grateful that we can share some of her life today with her respected colleagues, and I'll just take 5 minutes of your time. Our mum, Dr. Chalabi, was born in Najaf in Iraq. She was raised with 5 brothers in a deeply religious Muslim family and learned to read by her mum reading the Quran with her. When mum was about 12, our grandmother became ill with tuberculosis, and mum was pulled out of school to help care for her. Mum was kept out of school for 4 years, but she was always desperate to go back and would read anything that came into the house, like the magazines that her sisters-in-law would bring. Eventually, mum's dad agreed to her returning to school, but she would have to join a class where she was 5 years older than everyone else. Mum was determined to get her education and was not put off. By the end of the year, she was back in the class with children her own age and scoring the best grades in her class, as well as the best grades in the entire city. Sadly, Mum lost her mum Latifa when she was only around 14 years old. She was incredibly close to her mum, and this loss was so difficult, but it made her sure that she wanted to be a doctor and help others. After our grandmother died, Mum moved in with her brother Saeed and his family. Mum became the most loved and doting auntie at a young age, and all of her nieces and nephews remember all of the fun they had with her. Mum graduated as a doctor in Iraq, and she specialised in obstetrics and gynae. She quickly got a reputation for being really good at her job, and all the pregnant women in Najaf would ask for Mum specifically. Around the age of 27, Mum also lost her dear father Mohammed, and not long after, she decided that she wanted to continue her medical training in England. Mum worked in Manchester and across London in many different hospitals when she arrived in England. She learned English in medical school in Iraq, but I'm sure that coming here alone must have been a huge challenge. But in all the photographs of that time, Mum looked so happy and confident. Mum met and married our dad Ghazi when she was 34. He was also an Iraqi doctor working in London who specialised in paediatrics. When Mum was 35, I was born, and when Mum was 36, she decided to study for the MRCOG Part 2. She was 8 months pregnant with my sister Mona when she passed this exam. When we were in primary school, Mum decided to become a GP so that she could work more social hours and spend more time with us. She became a partner in a GP surgery in East Ham when she was in her early 40s, and we know that she absolutely loved her job. When Mum did the Muslim pilgrimage to Hajj, she prayed to God to bless her hands so that she could provide her patients with the best care. Mum was so proud of her work. When we were young, there was a big photo on top of the TV of Mum performing a cesarean that scared all the kids that would come over, but we thought it was normal. Mum had a happy marriage to our dad, but he became unwell when we were in primary school. It meant that every day Mum worked a full-time job at the practice, then would go and see him at the hospital before coming home to take care of me and my sister. We don't know how she did it. My dad was sick for 10 years before he died. Although they didn't have enough time together, Dad respected her strong will and intelligence, and they loved each other very much. Mum retired at 65 years old, and we were worried about her being bored and her health declining. But we were wrong to worry, and it was a joy to see how much Mum enjoyed her retirement and how much of a social butterfly she was. Mum was proud of us and would brag about our achievements, but she was always humble about her own. We've only discovered after her death the true extent of her giving to charity and her support for family and friends. Through all the challenges in Mum's life, she remained so kind and loving towards everyone she came in contact with. She was also so funny and mischievous when you got to know her well. Faith was something that Mum held deeply and close to her heart throughout her life. We know that Mum wasn't afraid of dying and that she was sure that something better waited for her on the other side. We know that our Mum, who lived her life in service to others, is now at peace. Thank you so much for your time and for letting us share that with you.
Thank you so much, Nabila and Mona. That's a lovely tribute. Really, really thank you so much for that. I know it's very hard for you both, but it was very, very touching. So thank you. And I know that there's an email going around just to see if we can put something in the newsletter, and if you're happy to put some of those lovely photos in. And yeah, what a lovely tribute. Thank you so much for today.
Thank you for having us.
Our thoughts are all with you and your family.
Thank you.
Okay, how lovely. That was so lovely. So let's go on to the next agenda item, if we can move on. Some lovely comments as well in the chat. So thank you, everyone. So I'm hoping that Olga is here, and Olga's here to talk about the 111 appointment slots. So I'm going to hand over to Olga.
Good afternoon, everybody. Oh, there's an echo.
Yeah.
Yes, that's better. Thank you. Thanks, Rima. Hi, everybody. So my name is Olga Bach. I'm the senior on-plant care lead for Newham Place-Based Partnership, and I've been asked to come here today to talk about the direct booking into 111 by Newham practices. I'm just going to show a couple of slides, which is just going to set the context for where we are today. I'm sorry I was not able to share it in advance. I've been in so many meetings over the last 2 days, I've not had time to do a presentation. But I'm just going to share a couple of slides that's just going to give you the concept. But before I even say that and do that, I'm sure everybody is aware that GPs are expected to make at least one slot available for every 3,000 patients on the list, based on the list size. So the expectation is, for instance, if you have 10,000 patients on your list size, you should be making 3 slots available and daily for one-on-one booking. So I just want to show you where we are to date in terms of that, and based on what GP Connect has shared with us. So, okay. So this is just one of many slides. Well, as you can see, GP Connect weekly uptake of utilization based on utilization rate, and this is specifically from Newham. I'll make it bigger because I'm sure you cannot see. Okay, yeah. So you could see this over the last, what is that, more than 12 months, you can see what the performance has been like in terms of utilization. Basically, depending on the slots you've made available, one will book into the slots. So in terms of the bookings that 111 has made, you can see that it's averaging around the 50% mark across the whole of Newham. I'll go into a little bit more detail in a bit, but you can see that in reality it's between 42 and I think it's about 55% or 60%. It was in November, but it's averaging around that. So what's that saying is that although, for instance, if you should be making, even if this was available, the booking coming in is only 50% of what should be coming in. So utilization is only about that. As you can see from the note there, it says that Newham saw a steep decline in GP Connect's utilization in August. And prior to that, utilization was either above or below the yearly mean. However, after November, performance taking them above the yearly average, December has taken them back below it. So you could see the main yearly average. In November, it increased a bit. It was about 55, and in December, it went down back to 47. The next slide is just giving a little bit more detail around that November, December performance. You could see from the PCN's perspective what performance is like. In reality, South 1, Newham and Newham Central above 60%. A few around the 57%, and the rest of the below. About 51%, that's about 41%. That's the utilization of what basically, obviously, if it's not utilized, you could see what the underutilization is like across the board. And this covers up from the 6th of November to the 31st of December. Just a little bit of breakdown in terms of each month. November, you could see what the utilization was like. As we were saying, it was 55%, and in December, it was 47%. And that's just giving it another view of performance across each PCN. That's just it by practice level. You could see what the highest practice in terms of utilization, which is nearly 99% for Glen Medical, and the lowest one is Dr. CM Patel, which is just under 20%. And this is just I'm giving it a breakdown in terms of that information I've just shown you. This next two slides are just giving you a breakdown in terms of what time of the day and what time of the week the slots are utilized. So you could see in reality, most of the slots are utilized between 12 and 8 in the morning, so 8 and 10 in the morning, and then it starts to drop between 10 and 12, 12 and 2, 2 and 4, 4 and 6, and then it starts to go up again between 6 and 8. So this is what it looks like on an hourly basis. And for Newham in particular, which is the yellow one, that is the highest utilization, as you can see, mostly around the 8 to 10 mark. And for the weekly performance again, you can see that I think Tuesday and Thursday is when the service is used more, when the slots are utilized mostly. Yeah, and that's it basically. So it's just to bring to your attention what performance is like currently, and just to encourage good practices. I mean, in reality, when you compare with other systems and other place-based partnerships, Newham is doing very well. There's no doubt about that in terms of making slots available and in terms of utilization. But I mean, everything it could be better. I mean, it's around the 50% mark at this moment in time, but we just are trying to encourage you to make slots available and so that utilize.
Thank you, Olga. Yeah, thank you, Olga, for that. So just for the purpose of everyone on the course, the utilization is these slots are available for 111, but they obviously directly book in the patients into these slots. So when you say utilization, I guess it's very much reliant on 111 using those slots when they are available. I know in the past we've had some question about what patients are booked into those slots, and some of them not necessarily urgent, but I know that Claire's done some work to try and get some of that feedback back from GPs to 111. So I think it's just you highlighting, making sure that practices have those 111 slots available, and the utilization is obviously from 111 themselves.
Exactly.
Yeah, perfect. Thank you, Olga. I can see Claire's got a camera on. Claire, is there anything that you wanted to add to anything Olga has said for GPs?
I think there's frustration on the commissioner's side that there isn't high rates of utilisation, but Newham's always performed very well relative to the other boroughs. So just thanks to all the practices that are doing that. I think there is some thinking that if there could be learning across practices, because some practices, their utilisation is much higher than others. But equally, I get the messages from the practices saying they're very frustrated by the profile of the patients that are being booked in because they're on the day appointments. So I know that Karen and Nadeem have been working with the NHC team to find a workaround around that. So I don't know if any of the NHC team want to feedback about how we're trying to make the practice experience better, whilst also meeting the practice's objectives as far as their contract, because we don't want you to lose the funding for this activity, but we want you to feel as though the appointments are used appropriately.
Thank you, Claire.
Sorry to
interrupt, Rima.
Yeah, I was just going to say, Paula was going to pick up this issue in her contribution in a second, or now, whichever's easier.
Rima, you're on mute.
Sorry, I keep being muted, I think, because we're trying to mute everyone. Sorry, apologies for that. I was going to say thank you to Olga and for presenting that today. I think we'll pick up the points with Paula with her item. Okay, so I can't see anything in the chat bar, so thank you very much, Olga.
That's okay.
It's all about the slots. Thank you. Okay, so let's move on to Paul and Poonam. We're going to talk about the spirometry service offer.
Hi everyone. Newham. I'll just hand over to you.
Hi everyone. I'm Newham. Is the echo still there? I think that's better. So thanks for having me. I just wanted to kind of update everyone, I guess, on the spirometry service and how things are going. So it's really just to let you know that the service is coming together really nicely. So we've onboarded our first ARTP trained clinician who has lots of experience, lots of knowledge in the field of spirometry. So we're really hoping that the reports that we're going to produce from our service will be to a really good standard. And all the GPs will find them really helpful. I've been having quite a few meetings with the PCNs directly. I've had quite a few already. We've got some in place for next week, and I think there's probably just a few PCNs remaining. So if you haven't already heard from me, please do get in touch with me directly or with Paul, but I will get in touch with you as well. And I think these meetings have been really helpful. Because it's really kind of given me great feedback as to what the GPs really want from this service, because this service is obviously for your PCN. So we're really trying to have that collaborative approach on how we can work together to kind of deliver the best spirometry service, that we can possibly deliver. And then we're just kind of waiting for some final sign-offs from the commissioners, and then we're pretty much ready to go. So we're going to be piloting the service with anyone this month, hopefully, once we've got everything signed off. And then after that, shortly, we're hoping to roll out to all the other PCNs. And like I said, it's just been really helpful having those really personal meetings with the PCNs, because we've really kind of got that feedback as to what the PCNs are looking for in this service. And I just kind of really wanted to accentuate how with this service, it is a really special service because we've got some great clinicians on board. And we've really tried to look at what does good practice look like? How can we implement best practice across Newham? So, for example, it's not just going to be a service where your patient comes in, has their spirometry test, and then they're sent back to the GP. We really want to use the concept of MEC, for example, making every contact count. So if we've got patients, for example, who are on inhalers, having a pharmacy background myself, it's really important to me that those patients are counselled on, their inhaler use. Do they need a referral to pulmonary rehab? Referrals to smoking cessations and things like that. So there's so much that this service has to offer. But it's really about working with the PCNs directly and kind of really figuring out how we can all work together. And I think something else that makes our service really special as well is having those links to secondary care as well. So having those, respiratory physicians and consultants on board as well with the service, it really means that, when we have those complex patients where we don't know how to manage, we can kind of escalate to secondary care, get their opinions, and then hopefully we can help better manage those patients in primary care. So that's it really. So if you do have any questions, please let me know, get in touch with either myself or Paul. But like I said, I will be in touch with every PCN, hopefully very soon. Yeah, I think that's it. I don't know if there's anything you want to add.
All good. Thank you.
Okay, thanks, Poonam. We do have one question in the chat. So if you can just give a bit of an overview, because obviously today we have sort of a lot of GPs from the practices within those PCNs. So it'd be helpful just to have an overview of the service. So Poonam's asked, who's running the service and where's the service located?
So depending. It will be dependent on, so once we have that meeting with the PCN, we can understand better where we're going to run the service from. So we're kind of taking a PCN hublet approach. So within that PCN, if there is a site that we can use, that's the approach that we're going to take, because then we have those consultation rooms available and the correct setup for the spirometry service. I'm leading on the service and Paul is also leading on the service. So if you've got any questions, please feel free to get in touch.
Okay, that's great. Thank you so much.
Just to add,
Paul.
So with Sheetle's question, within any one proposed to deliver it on the enhanced access alongside the enhanced access hub, so that will be run on a Saturday. And I think the site will either be Westbury. I think it's Westbury for any one PCN.
I'll mute myself. Thank you both very much for that. I can't see any more questions in the chat, but Poonam, thanks for the offer. You know, if any practices want to get in touch with you or Paul, then they can do so to find out more about the service. It might be actually a good idea to maybe bring this back in like, you know, once the service is settled in, and bring some of the information back to this forum in like 3 or 4 months' time, just to see how it's going. I think that might be a good idea, just to share that with practices. Okay, thank you very much. Perfect. Okay, I'm going to hand over to now Paula, who's going to talk about the clinical assessment service and the acute, I think, respiratory sort of hubs that are starting. And then Paula, if you just want to mention a bit about the 111 as well that was in the previous item, that'd be great.
No problem. Thanks, Rima. Hi, everyone. So I just wanted to give an update on where we are with the CAS, which is part of the pilots we're running for the same-day urgent access service that commenced in December. And as you'll recall, these pilots will run through till the end of March. So in terms of December itself, in the same-day urgent access service, as a total, we offered just short of 3,000 appointments, of which just over 2,500 were booked, which is a utilisation on offered appointments of 86%. That's a 5% increase on utilisation seen in the previous month. In terms of patients actually attending for those appointments, based on those that were booked, we saw 94% utilisation, which is a 2% improvement on November. Where we saw the most improvements was around the CAS itself. So these are the calls that come through 111 that are a primary care disposition, which come into the clinical assessment service, and then a telephone consultation is conducted by our GPs in the service. They then either close the call off remotely, refer the patient on to another service as appropriate, or they can be booked into a face-to-face appointment in a hub site that we currently run where the 111 activity is held. Sorry, am I able to move? I am able to move it on. So just in terms of some key highlights for the service, as I mentioned, overall utilisation has improved 5% since November. The CAS itself started on the 4th of December, so that's a 5% improvement since the CAS started, and a 2% improvement in attendance for booked appointments during the same period. Week on week, we're seeing around 14% of 111 calls being converted to a face-to-face appointment, and with 1% of activity requiring an appointment at the patient's registered GP practice for ongoing care after their initial appointment in the CAS. To date, we've seen 0.5% of the activity that has required a referral to A&E, and in those instances, we do provide feedback to the 111 team on the actions that have been taken for those particular patients. In November, the average number of weekly appointments that were available to 111 was 336. We're now averaging 410 in December, with 439 offered in the week beginning 25th of December, obviously Christmas Day. Pleased to say that there has been an increase in CAS bookings via 111 across all 9 of the PCNs. There's been no drop-off in activity at all. If anything, as I mentioned, there has been increase across the borough as a whole. For the South One pilot in particular, the agreement was that in hours, the PCN would see any 111 patients that needed a face-to-face appointment, with NHC managing those patients outside of court hours. During the month of December, only 2 patients required to be booked into a practice slot during court hours, and only 3 patients needed to be seen during the evening and weekend. For the Central One pilot, that goes live in February, which is when the EMIS eHub will be fully mobilised. And in the meantime, all of the enhanced access and same-day urgent access activity continues to be managed by NHC via the CAS itself. These are just some reflections from our GPs that have been working in the service to date. They all collectively feel that it's been a great service and seems to be working very well. In the first week of operation, we were offering 15-minute appointments. We've now reduced that to 12 minutes. So we've gone from 4 appointments per hour to 5. All of our clinicians believe that that was the right decision to make. However, due to some of the case mix, they do agree that the appointment time shouldn't be reduced any further. In terms of the mix of cases, they're seeing the usual expected at this time of year, so lots of coughs, colds, sore throats, etc. But they have also managed a number of quite complex patients that have required a much lengthier consultation. Since commencement, 2 patients have had to be referred to A&E, and as I mentioned already, those patients' details have been shared back to 111. As part of a learning event to flag the concerns that were then picked up by our clinician that could potentially have been picked up in the initial contact with 111. Our clinicians have reflected that the number and options of face-to-face appointments have helped enormously, as they're able to direct book into those appointments because NHC runs them, and they're able to do that as and when required. And that has helped a great deal, as there are a significant number of patients contacting 111, particularly at this time of year, anxious parents that would prefer their child to be seen face to face. And we have a number of options by which they can do that. I will mention more detail shortly, but the addition of the acute respiratory infection hub, which commenced on Monday of this week, has also provided an additional face-to-face booking option for our clinicians. Just in terms of next steps, and this also refers back to the 111, we are testing the Adastra platform for the NHC CAS next week. Therefore, the go live date for Adastra to manage the CAS activity is imminent. Once that goes live, the GP Connect activity will no longer be directly bookable into practices by 111. The activity will be placed into the NHC CAS queue. It will be managed initially through a remote consultation with one of our CAS clinicians, and then only booked into a practice GP Connect appointment if a face-to-face appointment is deemed necessary at that point by our CAS clinicians. So local triage of all of that activity. And we will be sharing further details with practices quite soon on how to undertake that change so that the appointments become bookable by NHC rather than 111. We will also at that point be adding additional clinicians into the CAS team, and that will include the addition of an AMP to work alongside our GP colleagues. As already mentioned, we will also be mobilising the EMIS eHub for Central 1, shortly followed, I believe, by Stratford. And we are also going to be reaching out to our practices and our PCNs with regards to furthering the discussions around a rollout of a 24/7 model with the support of PCNs and practices from the 1st of April, when the commissioning for the same day urgent access service moves over to PCNs. So that's the end of the slides on the CAS. Just in terms of the ARI hub.
Sorry, Paula, just before you go on to that, there was just one question in the chat, and I thought it's just easy if we cover that before you go to the next item. So it's from Dahlia from Custom House. So for the practices in the South, they still need to provide NHS direct booking slots in the practices. That's for South
Dahlia,
One.
Is that at the moment or once GP Connect goes live?
Okay, maybe we'll come back to that. I don't think Dahlia's got that message. Okay, we can always come back to that. Sorry, Paula.
That's okay. It's explaining that change.
Yeah.
So in terms, just in terms of direct booking, there is no need for South One to make booking slots available to NHC at the moment in hours, because we are only managing the out of hours element. However, once GP Connect goes live, you will need to change the GP Connect appointments to be bookable by NHC rather than 111. And we have sent some initial comms out on that. There will be further comms coming out shortly on the launch date for that. Hopefully that's answered your question. If not, please do feel free to drop me an email, or I can give you a call and we can talk through it in more detail. Sorry, just in terms of ARI. So this is an additional commission from the ICB to support winter pressures. You will recall that we ran a Strep A RSV service last year, and this very much mirrors the previous service. It commenced on Monday of this week, runs through till the end of March. The service is for children aged 0 to 16 with acute respiratory symptoms, most likely due to an infection. For instance, bacterial or viral infections, including COVID, RSV or flu. The booking process is by patients being asked to call the CAS direct. The reason for that and why we've not made the appointments available through cross-organisational booking is because the service is not available only to practices. It's available to practices 111 and UTC. The request from commissioners was that it was on a first come first served basis, so we are not able to reserve any appointments. So we are asking practices, if you have patients that you think would be suitable for this service, to give the patients or their carers or the family member or a parent the number for the CAS. They can ring through to us and we will then book them in for an on-the-day appointment. The service itself will be running 7 days a week from 10 AM to 3 PM. All appointments will be face-to-face. The CAS itself will be open at 8 AM to allow bookings prior to the start time of the clinics, which will hopefully help ease some of that pressure that you feel when your phone lines first open in the morning, in terms of being able to direct some of that activity for children through to the CAS itself. Monday to Friday, at the moment, the service is running from Greengate Medical Centre, and on a Saturday and Sunday, it will be running from Glen Road. We have seen bookings already this week from practices. In week 1, it was agreed that we would only make it available to practices, but from Monday next week, that will be expanded out to 111 and UTC. The reason it wasn't made available to those other providers this week was because there was already additional support in the system as a result of the recent strikes. We have located it at Greengate Medical Centre, mainly because whilst we have a lot of services running at Essex Lodge, such as the UTC divert service, we are very conscious that there are some space issues, particularly as you go towards the end of the financial year, where you may have more staff on site to help you with your cough achievement, etc. And we didn't want to negatively impact on any space that we currently need to use at Essex Lodge for other services. It is at Greengate until the end of this month. Potentially, it may need to move in February, March if Greengate have the same issue over space. But if the location changes, we will make sure that we update you on that. So just in terms, there's one. So it is essential. So it's being funded through the NEL winter plan for Newham. So it is part of the winter planning. And it's essentially an arm of the same-day urgent access service.
Okay, thank you, Paula, very much. There's a lot in there, and I know it's difficult to summarise everything, but I hope that's a good reminder of the services that we have in Newham that NHC are providing. So if anyone needs those numbers again, I wonder, I don't know if anyone could put something in the chat bar just as a quick reminder of a snapshot of the numbers. That would be helpful, and also in the newsletter. That's great. Yeah, thank you, Karen. There's a question about the winter access scheme, but I think, Paul, you've answered that. And then it said it's from Manuel, it'd be good to create an Accurex NHC CAS message as a suggestion. And then from Hina again, so the practice will not get winter access funds this year.
That I don't know anything about practice winter access funds, I'm afraid. This is part of the NEL winter plan for urgent and emergency care support. Rima, you're on mute, sorry.
It's not part of the practice funds. This is an NEL scheme. Right, any other questions or comments on any of that from anyone? No? Okay. Thank you very much, Paula, for that overview. It's really helpful. Okay, let's go on to the type 2 pathway from Oviva, and I think I've got, is it Caroline here? Sorry if I got that wrong. Hi. Hi, welcome.
Thanks everybody for allowing me a slot on the session. I can hear feedback. A bit of an odd call, but never mind, I'll carry on. Yeah, if you could go to the next slide for me, that would be really helpful. So yeah, first and foremost then, I just wanted to give a brief reminder of what the service is for. So essentially, the T2DR is pathway to remission for patients with type 2 diabetes. And within that 12-month programme, we're looking for significant weight loss, so between 10 and 15 kilograms, improvement in HbA1cs, and reduction in meds. And obviously the main driver is the potential for the diabetes remission. If you want to go to the next slide, please. So I have NEL's total, all the boroughs information. So far we've received 823 referrals. 621 of those have been accepted, so that's 71 that have not. The majority of the ones that are ineligible were ineligible upon referral. So again, within the referral form, just a reminder that at the very end of the referral form on your clinical system, there is a page that tells you the ineligible and eligible criteria. So please do check that, because I appreciate the form is quite chunky in places, and I don't want people to fill out the form and then it obviously doesn't go to fruition. So just as a reminder, if people could just check the criteria. Where I'm noticing the kind of trends are outside of the date of diagnosis, so it does have to be within 6 years of date of diagnosis. Sometimes it's BMI that's slightly adrift, and sometimes it's just maybe the date of birth. So they're kind of the three key areas really. So individual assessments, we've had 332 patients go through, and we've had 202 patients actually start the programme. I would say these numbers are at the end of December. We've currently got, January is obviously quite a key month for people to start, so we've got 98 possible starters that haven't yet booked in but are at that point where they absolutely could. So the numbers of the TDR starters are seriously going to improve, which is fantastic. We're currently on an average for the 12-week TDR, which is the total diet replacement part of the programme. I'm losing 8.5 kilograms, and 86 people have done so far. But again, there's quite a few people that are imminently just going to pass those 12 months. So January's numbers will be really positive. If you do the next slide, please. So I think the first thing to say to Newham is thank you, because actually the key numbers that I look at is the TDR starts, because they are the places. And actually, as a percentage of eligible referrals, Newham is the best performing area. So thank you. That just shows the quality of the referrals that are coming through. So that's really, really good. But I thought it's always good to be nosy and see what everybody else is doing. So as a total for Newham for June to December, we've had 101 referrals, 75 accepts, and 32 TDR starts. So a really good start. Overall, I would say we've got 500 places over 2 years, and NEL as a whole is on track to achieve those at the moment. We'll definitely exceed the 250 for the first year, and that's absolutely fine to do so, because it is a tough programme. We know it's not for everybody. We know asking people not to eat food for 12 weeks is quite a big ask, but I can really see from Newham that those quality conversations are obviously having, and it's getting people through and onto the system. So again, just you know, more of what's happening would be fantastic. If you could go to the next slide, please. I won't go through this in detail, but just to show that out of 43 GPs that could, 21 have referred in. So we do still have 22 practices that haven't sent any referrals in. So I would say to those 22 that if you have any questions regarding the programme, please do email in. We do have a drop-in session on the second Tuesday of every month. So we've had January's, but we'll have February's now next time. If you do have any issues, any questions, any scenarios that you want to ask that you're not sure and that's why you haven't sent any referrals over, then please do come into that drop-in. But in the meantime, if you want to send me an email or the T2DR inbox an email with a question, please do that. But there's still loads of opportunity, that there must be more patients out there that are eligible. Like I say, I know it's not a walk in the park. I know it's quite a difficult programme to get people to come on to just because of the, you know, not eating food. For those GPs that haven't sent any through yet, I would say that if you have any newly diagnosed patients, for the speed of the referral form, those patients probably aren't on any meds yet, so that takes a whole chunk out of filling out the referral forms. Even if you just concentrated on those cohorts of people just to get some through a few people, that would be fantastic. But like I say, the 21 that have, they've been a good quality of referral, so thank you. Next slide, please. Just as a reminder, as I say, for the inclusion and exclusion, I won't go through it now, but it is all on there, just as a reminder. Sort of what the parameters of the definition for NHS that have set for us for people that are in remission with being on meds and not being on meds. We just got to make sure that HbA1c is in check as well. Yeah, so it is available, the referral forms, on EMIS, it is on System 1. If anybody has any issues, then please do let me know if you can't find it. What we usually recommend as a search is just putting through remission. That seems to bring it up quite often, if that's helpful. Okay, so if you want to go to the next slide. We've got the participant journey here again, because it's not new news to everybody. I don't want to sort of go through minute detail, but just wanted to say that these slides will be shared with you and the journey is on there. But just as a reminder, once we get the referral, it is that 12 weeks of total diet replacement. We use different companies. We can tailor it for vegan, different cultures. We can advise on ways to make it taste better by putting paprika in, or all of those things that, you know, just to try and make it a bit more interesting. We only ask patients to book their TDR 4 weeks in advance, because obviously after 4 weeks and you're doing it for 12, you might want to change it up a bit after 4 weeks. ICB is the commissioning for this programme as well, so that's a question. So after the 12 weeks, the biggest important part for Oviva, I think, is the reintroduction of food, because people have lost hopefully a significant piece of weight from weeks 1 to 12, and then it's all about those conversations about how we reintroduce their food, how we support them. If we notice that they do put some weight back on, which inevitably after not eating food to eating food again, it's a possibility, we can allow TDR to happen. Maybe they just need to have it once a day or twice a day just for that month, just so they can kind of really get back into what works for them. But then we are with them up until 12 weeks of 12 months of the programme. What we do ask from GPs is that we have a 6-month review and a 12-month review with those patients. But in the meantime, we really keep on top of any kind of issues that that patient might have. If there are any adverse effects or events, we obviously keep you updated. Really, the biggest thing that we notice is that people might have constipation, dizziness or diarrhea. We do offer, that's part of the contract, a fibre supplement to everybody. So we do advise that people take that, because that helps obviously for the constipation or diarrhea, and keeps that kind of at bay. But we do keep in contact. We make sure that if there is anything, we do let you know, and we get that emailed over, and we also ask the patient to get in contact as well. But we really find that these kind of adverse effects are very, or side effects are very minimal. But yeah, so that's kind of a quick overview of what the participant journey looks like. If you'd like to go to the next slide. As referrals are coming through for the majority, I would say that these steps are in place, but for any GPs that haven't sent anybody in, like I've said, maybe look at your newly diagnosed, or perhaps you could run a search on your system of people that have been diagnosed within the first 6 months. I've got lots of tools that can support you with referral or searches. So again, just reach out if you need that. I've got comms that you can send as a text to patients, that you can send out to get people to invite them to come and book an appointment. But we've got lots of tools. You'll see also on the bottom of this slide the email address. So if you do have any questions, please do email that. That is where you send the referral form, and that's where our onboarding team are kind of waiting for any queries. They will then pass your query on to either a clinical person or an operation person, depending on what your need is. Next slide, please. So just a brief look at the referral form. The main part is the middle section with the meds changes. Again, we don't want anybody to do any meds changes until they day one start their TDRs. That's always an important message to share. But again, the first page is pretty much auto-populated. We just ask that you check it against the criteria. And the last page is just in case you need to tell us any other detail that you think would be appropriate to let us know. Next slide, please. Just wanted to show you a bit of our technology that we have. So every person, whether they choose face-to-face or digital, because we do offer both pathways, will get our app. Just a really easy way for people to keep on top of logging all of their moods, exercise, foods, all of those things. We're really appropriate. So if somebody's on 12 weeks of not eating, we don't send them recipes because nobody wants to see that while you're on shakes and things. But once they come off of that, we're introduction of food, we do send them suggestions through. It's really good for our dietitians and our coaches to be able to also review patients by what they're putting through and keep an up-to-date log of what's happening. Next slide, please. And then just ever so quickly, I think photos of people in the programme is always something really good to look at. So we've got Felix here, looks like two different people. Yeah, just his happy smiling face at the end. So he was on the previous LCD pilot programme. He lost 33 kilograms in the 12 months. He reduced his HbA1c to 37. He's no longer on any meds. And he's now running marathons, which he tells us is something he absolutely never thought he'd be doing, and he really looks forward to it. And he does park runs on Saturdays and all sorts. So his life has completely changed. But yeah, so he's really great to see. And then the next slide is Heidi. And again, I do like to show Heidi because her photos are only 16 weeks apart. So she's done 12 weeks of TDR and 4 weeks into reintroduction. And again, I think the photo, I don't need to read all the words, the photos just speak for themselves. So really makes a positive impact. Often we find that our patients that are joining us have tried everything to try and shift some weight, to try and not even necessarily just for remission, but for everything else that obviously weight loss supports. So what we're finding is for those people, this really does work. But the key thing is your conversations that you have with those patients in the meantime. And within a surgery, it should, although the referral is kind of owned by the GPs, absolutely it can be a tag team approach in the surgery, because I appreciate the diabetic nurses often are the ones having those conversations. So anybody that prescribes can send the referral in, but if it's also done as a tag team where non-prescribers are filling it in, it does then have to come from the GP, but it can also take some of the workload off. And sometimes I get that in other areas in the surgery, they might be the key people that are more in contact with the patients, so they could always get the patients interested in the program to book their appointments in. If you can do the next slide, please. I won't go through this one, the next one, or this one. I'll share the slides so you can look at them separately, but this is all of our links. We've got the engagement in a video form. There's an hour long, there's a 15-minute one. It's got the link for our drop-in centre on the second Tuesday of the month, and just some useful meds changes information as well, because we find that's probably sometimes that's a bit more complicated for people that are on meds. But yeah, feel free to use those. And then I think that's the last slide, apart from a thank you. So I appreciate I've gone through it at breakneck speed, but hopefully you've got everything you want. Please do reach out if you do have any questions. Always happy to help. If you have any other engagement sessions that you'd like me to attend, I don't know if there's nurse forums, or I don't mind. If you think that would be prudent, please let me know. Yeah, happy to attend. But thank you very much for your time, and well done to Newham for being the best out of all of the nail boroughs. I think that's always nice. But yes, does anybody have any questions for me?
Thank you, Caroline, very much for that. There are a few comments in the chat. Just before we get to that, I think it's great that Newham are, you know, quite up there with the referral rate. I'm not surprised with incidents of diabetes that we have in the borough. My only concern was we have a very diverse population in Newham, health literacy rates very low. So I wonder how we're also capturing people where English is not their first language into this programme, and whether you have different ways of then reaching out to them and providing the program for them, because we have, you know, significantly high proportion of those with type 2 diabetes where English is not their first language.
Yeah, if the patient chooses a face-to-face pathway, we can't offer a can't think of the word. We can't offer that we can't guarantee that our coach will be able to cover every single language. Obviously, we've got quite a diverse population of coaches as well, so we may well be able to. However, if a patient is choosing the digital pathway, then we can use a translating service. The only thing I would say about face-to-face is if that patient wanted to bring someone with them, they absolutely could. That is not a problem. So often we find that that's the case, but we absolutely will always make sure that there's room for a couple of people, 3 people within the face-to-face room. But yeah, but we have with Oviva 23 in-house different languages spoken as well. So but we can use an outsourced company, but we often find again within our kind of far-flung across the UK, we're able to do those translations in-house, which then makes it a better experience because it's not going through somebody secondhand. We don't currently have the opportunity to have our app in different languages. It is only available in English, but what we often find is it's because it's quite picture-led and graph-led, and it's quite clear what information you're putting in, that doesn't really seem to be too much of a problem.
Okay, that's great. Thank you, Caroline. So there was a question about the form, and I presume you went through the referral form, and it is on EMIS, just to remind everyone. Excuse me. And then I think someone from Stratford Village, Annie from Stratford Village, was just questioning some of the data there. So I don't know if you want to contact the surgery directly just to double check those figures, because I think they feel that they've referred more patients than what was presented.
Was that though up to December, because we've had quite a few more come through in January?
Hi. I think from the onset, we had referred quite many patients, and I'm quite surprised. And I saw some of your letters you sent, or I think when it was just not Oviva, the prior services, you sent some letters as well about how many surgeries had referred in Newham, and Stratford was among them. Stratford Village Surgery was among them, and I think we had maybe 6 or 7. I think up to now, maybe about 20, if not more, we had referred.
Just having a look on my slide quickly.
It's saying 0 there.
Okay, I'll definitely go in and double check, and then I'll come back to you separately.
Thank you.
Okay. But yeah. Oh yeah, it's Stratford Village Surgery. Okay, no problem. I'll come back to you. Thank you for pointing that out.
Okay, thanks, Carol. And then there was a message from Manuel, who's from one of the PCNs. He's keen to invite you to one of the PCN meetings. So I don't know if your details, I'm sure we've got your details, so then Manuel can directly liaise with you. We do have our nurses forum as well. I don't know if Tammy's on the call today in terms of the kind of the diabetes side of things, whether it's worth, there's a, you know, the diabetes MDT, and whether nurses within that MDT are aware of this. I presume they are. But Tammy is our diabetes lead. I don't know whether you've liaised with her directly. Yeah, you have. Okay, that's great. So that's our port of contact for Newham. Great. Any other questions, comments? Anyone had any experience with the service that they want to share from patients? No. Okay. Perfect. Thank you very much for your time today. Thanks for reminding us of the service. Perfect.
Thank you.
Okay.
Good day. Thanks,
Yeah.
everyone.
Thank you, Caroline. Right, let's move on to CQC notices. So Dr. Sen, over to you.
Thank you, Rima. Thank you, everyone. It's a Friday. I don't want to scare people too much, but then let's see what I can do. You probably have weekend to recover from what I'm saying now. So what exactly happened? Most of us had 3 cycles of visit already. And CQC started doing desktop review from last Monday. So most of those practices are now safe and effective. You have a policy regarding safeguarding, you have your DNS CPR, you have your prescribing policy, all these things are in place. So we just have to maintain the safety and effective domain. The most mobile part and most important part of NHS now is the access. And what CQC is going through now is going to see your access data. So when I say access data, that means, are you giving a right patient, right access, right mode in the right time? Okay, so they are going to see now in 7 areas. So when they're going to go through your data analysis on the response lead, they're going to see patient-centeredness. That are you providing a service that meets the patient's individual need? Okay, then they wanted to know that is that care provision are integrated with other system of the service. So is it with out of hours? Is it connected with extended access? Is it with the parts? And is there any continuity of care? Because nowadays continuity care is very difficult because continuity care and access is a trade-off. If you want to give it continuity of care, you have to go to the 20 years back of general practice where single-ended GP used to see every patient, knows by the whole generation. The things have changed. People comes and goes. The continuity care has disrupted. Now, the provide information. How do you provide people information? So I'm a Bengali man who works in a meat shop, and I wanted to book an appointment with my GP. So I go to the website. It's so colorful, so much, but I don't understand what you're talking about because the English is not my first language. So what kind of adjustment you did for me? It doesn't have to be written. It could be a verbal, it could be an audio visual. Somehow I, as a Bengali man at 62, this is not the time that I can learn English. But what I can do, you can provide me some kind of way so I can book an appointment. I can speak to a person the way I understand. So that's the providing information. Also accessible information, how you provide them, whether you get a audio visual. So those kind of information has to be there. And I know it's quite a lot of difficult job to do, but this is the people are looking for, that how you are really providing service for all your population. So then listening and involving patient. So it's a very difficult to engage in the patient participation group, but I wanted to see that every year practices are meeting the patient participation group and listening to them and made 5 changes. Is 5 changes could be the time of the appointment, it could be the type of the appointment, the mode of the appointment, what happened after the appointment, so any kind of thing. So the patient might say that we came to, your surgery is too crowded. Patient might say, so you have done something with the patient. So you need to say that you involve with the patient with the discussion. At the same time, you make a changes. So that's probably you already doing it. But if you don't do it, start from now. Equity of access. So all these projected characteristics people, are you giving them enough access to, in a way they feel comfortable that the teenager can come to the surgery after the school or after the college in a protected, in a safe environment. They can see a GP who can really feel comfortable about. So those kind of things. I know them asking too much, but that's the way the game will be now, because we are all safe and effective. We just have to make sure that we have enough access. So equity in experiences, how are you getting information from me who is, I just work in a meat shop and I only can understand Bengali. So how can you are gathering information from me that how I like your service, what needs to be changed? Are you doing anything in Bengali? Are you doing anything on Polish? Are you going to do any other language? So we wanted to do that all the collecting data you're doing are doing in a different way, so everybody can participate in your service development. What are you planning for the future? What are you going to do about winter outbreak? All these things that we already done it. So next slide, please. I cannot go about all these 11 slides now, but only things I will talk about now, because in this slide, it's a very heavy slide. And at the same time, I put down about what evidence you need to produce. That's need really 90 minutes to 1 hour to go through. Okay, that's not doable now, but I can arrange something on the Vicarage Lane. You can come like we used to do it before, and I can go to the evidence. Only things I wanted to tell you people now, your DNA policy. The DNA policy is extremely important because what we are asking for to give DNA a positive outcome. What happened nowadays? What happened? So when the patient DNA, you ask practice manager, say one of the receptionists to give the patient ring. So usually this is happens. If something happens differently, I'm sorry, but this is the maximum things happen. The receptionist ring to Rima, say, Dr. Vaid, you had an appointment to see me at 4:30 today, and you didn't turn up. But you should have told me beforehand, so we can give this appointment to somebody else, and then that's probably saved and it's just money. Does it have any impact on patient? Patient probably preparing the child to go to the bed, patient probably going to bring the children from the school. That conversation has got no impact. Because what you are putting a guilty on patient's mind. And that is not the way. It happens all the time, and it's not something new. This is the way we are trained for. That is the negativity bringing to the patient, and the patient feels frightened. Patient might even say, I didn't go, I don't care. And then you get an NHS net, you go to the patient choice, a big letter about you. That's not helping anyone. Okay, so what we want this way. I rang to Dr. Vaid to say, hi, Dr. Vaid, you had an appointment to see me today. Unfortunately, you cannot turn up. Can you just advise me if I could have done differently, that you'd be able to make this appointment to be happen? So what we are asking patient to give you feedback in a way that you can implement some change. Patient might say, I'm sorry, I've forgotten, so you can give a reminder, or a patient might say, sorry, that didn't suit up my time because I went to pick up my child. So that means that you need to restructure your appointment system. And they say, oh, okay, I wanted to see a female doctor, but you booked an appointment with Dr. Sen. I don't feel comfortable to talk to him. That might also give you a chance to redesign your service. They might say, hang on, I booked the appointment 2 weeks time. My cold is gone now. So that means you need to really think about how you're releasing your appointment. So what you do instead of doing it, we put down a big poster on the reception to say, this year we have lost 500 appointment. That leads to a £6,000 loss for the practice. That is not the way we wanted to do anymore. We want you to implement the DNA policy in a way you can engage with the patient to really reduce the number of DNA, not to just creating a negative environment when the patient doesn't come and discuss with you anything. This is the one of the things that I wanted to really people to get engaged. So if you can just start doing, I know it will take time. I know that the practice managers will not be happy the way I said that who got the time, but that's not an excuse, because as I said, they're not going to look at your safety effective to come to you, but when they come to you, then they will look for. But in order to assess you, they wanted to know how responsive your service is. So as I said, it's very difficult to go through all the presentation now. But if I have a chance to have 90 minutes to 1 or 2 hours somewhere, I can sit down with you and can discuss about all this the evidence you need to produce. The new regime started from last Monday. Some people will already get the notification. Some people will get next week. So I think this is the time to find out. Go to NHS Choice, see what comment people are putting on. Look, if there is a safety concern that came from GMC, a safety concern came from patient whistleblowing, that's different. I'm talking about 80% people. The 80% people who are doing moderately good things, this is the way CQC is going to pick up that how you managing the winter pressure. Yeah, I can see there is a hands on. Yeah.
Yeah, Manuel, do you want to come in?
Thanks, Ubia. Excellent horror story, but is there a real practical help to actually for practices to like, for example, a standard template that we could develop? And because there are a lot of work that's happening on access improvement, and also one of the submissions end of last month was actually moving towards a modern general practice, and there's a lot of access work, digital transformation. It would be good for us to put something like an example, a sample sort of evidenced document to help the practices. And then all they will need is like where to go and collect the information and update that template. Would be a very good approach to support the practices.
Yes, Mendel, that's probably we're going to do it. There's a 5P. 1P is the passion factor. What kind of characteristics is this patient, whether this patient can come that time. First P is the patient. Next P is the practice. Does the practice have enough information, enough appointment to give to the practice? Next one is the practitioners. Does the patient want to treat this particular patient? It's a gender bias, this could be a time bias, this could be many other things. Then you have the profile, P. That means, is that patient belongs to the disadvantaged group, that profile, is it right time to give a disabled child to come at 5:30? So that will be DNA anyway, because that's what. Then last one, you can think about it, how a pound factor. That means how you can really release those kind of effective appointment to make sure that you don't have DNA. You bring more appointments to your system. You don't have to have enough locum or salaried GP to do it. So if you do this way, I know it will take time. The grid I will provide that you have to fill it up, and then you can do it next month another audit to see does it improve the patient access. So that is the way you can do, but that's probably a template I can provide. That's fine.
Okay, thank you. Thanks, Dr. Sen. So I know there's a lot of information. I know Karen's put that in the chat just now. That's kind of behind all of this, so we'll be sending that through, and Steph's put something in the chat that she'll be sending that through. And there's also an ask, Dr. Sen, if this could be discussed at the PM forum as well.
Yeah, that's what I'm doing that. Yeah.
Okay, so I'll leave that.
The PM forum, I really need nearly an hour. Okay, and in this discussion, doctor doesn't need to be there, because this is all about it's all about the.
Okay. So we've got that forum, and I wonder whether there's any time to maybe if GPs wanted an extended sort of time with you, Dr. Sen, to go through this. I don't know if has this come to PLT before as part of a CQC item. That could be an option, but we can think of maybe in a.
Yeah, so some of the GPs like shared management plan, then those kind of things really has to be there, and it is occupational, and then it's only one slide. There's 11 slides.
Okay, but I'm just trying to think of there's an ask to see if we can just have another meeting or forum where this is just discussed once, in a bit more detail. But I think the PM forum sounds like the right thing to do first, and then we can then take it from there. Yeah. Okay. Thank you, Dr. Sen. Right. Next, Karen, is there anything you wanted to add on Paul and
just very quickly, because Paul and Paula have covered a lot.
Yeah.
Just to say, I'm aware that quite a few of staff colleagues are struggling with ill health, and COVID is still doing the rounds. So just to share with you that the COVID jabs offer has been extended to the end of January, and our roving team at SLG can do staff members. So if you just reach out to the roving team or anyone at NHC, we'd be more than happy to arrange for your staff to book in and get those appointments if for whatever reason they haven't yet had their jab. And that was really the only update to share. Rima.
Thank you very much, Karen. And I can see there's a wonderful slide here celebrating some great work from the workforce awards that was held before Christmas. So well done to Vikesh, well done to Wax, and well done to Imrana. Great representation from Newham, so well done, and all that hard work's been recognised. So congratulations to you all. Right.
Sorry, Rima, I should have flagged this. We are in the process of preparing some videos for patients that are more nervous or for a variety of reasons aren't taking up the vaccine offers. And we're looking for interested residents and staff to be involved. So you'll see there's a ask as to whether people might be able to assist us with these. And if you follow the links, it asks a few questions so that we can hopefully get those videos as tailored and as appropriate to patient cohorts and staff cohorts. And that way, when we've completed those and we can share them out with the whole of the Newham system, they really will address the issues that we know you see on a day-to-day basis.
Okay, thank you very much, Karen. Right. So we just come to the close of the meeting, which is good timing. Is there any other business from anyone? Any questions anyone would like to ask, which hasn't been covered today on any items of the agenda? Anything else? It's just an open session. Anyone want to ask anything? No? Silence? Okay.
Hi.
Hi,
It's Neil here. Just quickly, if you can kindly raise any other forums just regarding X-rays and other radiology, and that we don't have any community provision available in Newham. So Shrewsbury Road was closed off and now gone as well. So our patients can only go to Newham General for a walk-in, and Whipps Cross only do it by appointment only.
just going to unmute myself, Anil. So that was all changed when the diagnostic centre, basically they had produced diagnostic centre hubs across the Nell footprint. So I think that contributed to that closing at Shrewsbury. I mean, I could take it up in terms of North East London, but it's unlikely that we're going to be having any other more openings of services in Newham apart from Newham Hospital itself.
Yeah, the only reason why, if you're telling us to try and stop using A&E, we can urgent X-ray in the community. It's really hard sometimes to not know Newham, or there's nowhere else to go. Lead times are very restricted. 9 till 12, and then again 2 till 4:30. When you go there, our patients are telling us they're waiting 2-3 hours on occasions just to get an X-ray done or something. So we talk about access and all those things. We just need to really push for some more provision. But just bring it out there.
Yeah, no, thank you, Anil. I can take that to the diagnostic board for consideration to see if we can try and do something. But yeah, I totally agree with you. It's really not good for our patients and residents. Absolutely.
Wonderful.
Okay, anything else? No? Okay. Well, thank you very much for your time today. Thank you again, once again, for NHC for putting this all together. I know it takes a lot of time and effort, so I appreciate that. And yeah, if there's any other questions, comments, then please feel free to email me or any members of the NHC team. So thank you for your time today. Have a lovely weekend, and I'll see you all soon.
Thank you. Bye-bye.
Bye.